we're here today to speak about parent advocacy. My name is Kaitlyn Hougham. I am the Retinoblastoma Research Program Manager at the Hospital for Sick Children in Toronto, and I'd like to introduce you now to the panel. We're lucky today to have Sarah Green with us, who is a pediatric nurse practitioner from the Children's Hospital of Los Angeles, and she'll be speaking to us about advocating for a child with retinoblastoma. We also have Amanda Brody, who is a child life specialist from St. Jude's Research Hospital, and her talk will be preparing, supporting, and advocating for children with retinoblastoma, speaking from a child life perspective. And then we also have Sarah Hancock with us, who is the mother of Damien, and also the Team Damien founder, and so I'm sure many of you are familiar with Sarah, and she'll be speaking to us today about parent intuition. Okay, so my talk today will be showcasing the Canadian retinoblastoma patient engagement strategy. So to start with, I thought I would just give a brief definition of patient engagement in research. So patient engagement in research has been defined as a meaningful involvement of patients, caregivers, clinicians, and other healthcare stakeholders throughout the research process. And this includes at the beginning of the research process, a topic selection, all the way through the design and conduct of research and the dissemination of results. And to have patient engagement in research, this requires a shift in the research paradigm that really aligns funders, researchers, and policymakers to the needs and priorities of those who actually experience retinoblastoma. And the benefits of patient engagement are that they, of course, align our limited research funds with the needs and the priorities of our patients, improves the quality of research results, and it's also been shown to increase the uptake of research findings and thereby have a quicker improvement of patient outcomes, because as many as you know, there's an estimated 15 or 17-year gap between when research findings come out and they're actually taken up into practice. So by including patients in research, that gap should be closed. And I just wanted to very quickly mention that, as the definition alluded to, that there really is a place for patients at every step of the research cycle. This is one of many different schematics that tries to highlight the research process, but patients truly can be authentically involved in every step of this process, and that's something that we're really trying to accomplish in Canada. So just to give you a couple of examples, we've had patients involved in grant writing, for instance, patients involved in collecting data, analyzing results, and you can also have patients involved in disseminating results, and their involvement should be not tokenistic, but true, really meaningful involvement. And we see patient engagement in research in the popular media. There's also a new journal called Research Involvement and Engagement that has patients involved in the editorial process. And we see some peer-reviewed manuscripts have come out speaking about, specifically in the field of ophthalmology, how we can include the patient voice in a meaningful way in research. And in the same way, there's groups internationally, this is just a few that I'm aware of, that have interests in ensuring patients are engaged in research. So it's becoming very popular, thankfully, and funders are also calling for this now in a lot of the grant competitions, as many of you may know. And so this inspired Dr. Helen Damaris to create the Canadian Retinoblastoma Patient Engagement Strategy. And this strategy aims to facilitate sustained involvement of Canadian retinoblastoma patients in research. And we've had 4 accomplishments since this strategy came together that I hope to very briefly showcase for you all now. And so the first accomplishment is the Canadian Retinoblastoma Research Advisory Board, or CRAB for short. And this advisory board was designed to oversee the larger strategy that I'm talking about. And so the board is comprised of more than 30 different members, including retinoblastoma survivors, parents of children that have or are affected by retinoblastoma. We also have researchers, clinicians, genetic counselors, social workers, policymakers. They're all part of this committee. And the idea of this committee is to really make sure that this strategy is authentically involving the full retinoblastoma community and that it is sustainable. This group will be what pushes the strategy forward long term. And we get all our work done through 3 working groups. So all of these members have self-selected into 1 or more working groups that meet monthly, and these working groups really bring the strategy to life. So we have a series of different social media that we use to recruit for the advisory board and for the larger strategy that I just thought I would put up here and consider following us. We have our Twitter and Facebook, and also a website, which is rbresearch.ca, so feel free to check us out. And we've had some really great students who have pushed the strategy forward. This summer, our students started to prepare some of these great social media pieces to help garner some interest in what we're doing. So this is a little image that says, when you realize all the ways you can get involved in retinoblastoma research, it's pretty exciting, and it's an image of a little boy who looks surprised. Similarly, we have a little girl covering her eyes saying, tired of all the jargon used in retinoblastoma research, we were too. And so we found these to be effective. I'll speak to some of our numbers in a minute, but some of this social media work has helped gather some folks from across the country to be involved in our strategy. So that was the advisory board that's helping oversee the strategy. One of the accomplishments of the strategy were a series of focus groups that were conducted. And so the focus groups were intended to uncover experiences, knowledge gaps, and research interests of people affected by retinoblastoma in Canada. And focus groups are, as many of you know, they're discussion-based forums to collect information from our participants. And so we did 4 of these discussions with a total of 34 participants, and they were conducted in 2 urban settings in Canada. But we also invited other Canadians from remote areas or who couldn't travel to join us through video conference. And our focus groups, in short, we're still writing up these results, but they found that participants of the focus groups shared with us that they were very interested in being involved in research. And some of the motivating factors for research involvement were that the participants stated they wanted to give back to other families affected by retinoblastoma. And we also saw a really profound interest in giving back to the medical community. So a lot of participants shared with us that they felt indebted to their healthcare providers and saw the research team as an extension of the healthcare providing team and wanted to give back. And of course, as we expected, there were barriers to being involved in research. So some of the participants in the focus groups shared with us that their time was constrained, and so that might prevent them from being engaged in research. And also they were concerned that their training might not be sufficient to be engaged in research. But speaking to that last point, as I mentioned earlier, I think one of our jobs is to educate patients in the many ways they can be engaged in research, that it's not traditional, what some people might think of sitting at the bench, analyzing microscopic molecular research, which I don't do. It's, there's many, many meaningful ways patients can be involved. The third accomplishment that I'm excited to share with you today is the Canadian Retinoblastoma Research Registry. So this registry was created as a way for our strategy to start to collate all of the individuals across the country that have been touched by retinoblastoma in any way. And we wanted to use this registry as a way to help disseminate retinoblastoma information to people across the country that have been affected by retinoblastoma, but also as a potential way to engage people affected by retinoblastoma in research as traditional participants in research, but also in these other less common ways that I mentioned earlier. And so when registrants sign up, they're invited to agree to be emailed information about retinoblastoma, and so this can include research results and other updates. And they can also agree, if they would like, as I mentioned, to be contacted about research studies that they might be a suitable subject or team member for. So those are the 2 types of participation in our registry. And to date, we've only been launched for a few months, and we're quite excited to have 40 registrants already in this registry. We've just been recruiting through social media and with the help of the great healthcare providers across the country. And almost all of our registrants agreed to both parts. So they agreed to receive information, but also agreed to be contacted about research studies, which is interesting. We are seeing the lion's share of our participants are female, and they're in the age group of 30 to 49 years, and about half of our participants are from urban areas. So this helps us target some of our recruitment strategies to the folks that are underrepresented right now, because we're really committed to making sure the registry represents the full Canadian retinoblastoma community. And this just shows you geographically where our registrants are located. So we're quite pleased that we have representation from almost all of the provinces that make up Canada. The participants are predominantly in the southern parts of the country, which is where we see most of our population. But we still have a lot of work to do, but we're excited that they are spread out across Canada. And our registrant, this is a schematic just trying to show you who our registrants are. So as I mentioned, there's 40 registrants, many of which are parents or guardians of children that have been diagnosed with retinoblastoma. Some of those parents are also survivors themselves. And we also have some grandparents, some spouses of retinoblastoma survivors, and also children of retinoblastoma survivors. And there's, of course, overlap in some of those categories, as you would expect. And then just very briefly, the last accomplishment of this Canadian retinoblastoma patient engagement strategy that I was hoping to share with you today is a priority setting study that we've just started. So the purpose of this study is for us to identify the top 10 retinoblastoma research priorities in Canada. And this is really important to make sure that our research is aligned with what the entire retinoblastoma community, including patients and researchers and scientists and clinicians, value. And it will help us align our research funding with what the community wants to see researched. So the way this study is being conducted is a 3-step study. It is very loosely adapted off a common methodology that's often used to set research priorities. But this first step of the study, which is on way right now, it will gather questions about retinoblastoma that participants would like to see answered by research. So there's an online survey that clinicians, allied care providers, patients, et cetera, can all partake in on our website. And in that survey, participants are invited to tell us any questions they would like to see answered by research. We'll then take all of those results, collate them and clean them and distill them down, and then we'll rank those questions. Traditionally, that ranking is often done by another survey that's again on the web, and anyone's welcome to participate in ranking all of the questions that we receive. But we may also consider doing that by steering committee consensus, which is another way we've seen that done in the past. And then the last step will be to take the ranked list of questions to a workshop that will happen in person in December in Toronto. And we will go through a series of consensus building exercises to take the ranked list of 30 or 40 questions that we reach from step 2 and distill it down to top 10 retinoblastoma questions that everyone hopefully will agree on, and that will set the research agenda for retinoblastoma in Canada moving forward. I think that's everything. I just wanted to take a minute to acknowledge all of the retinoblastoma families across the country that have been kind enough to be involved in our strategy and contribute their great ideas and that are part of our CRAB group. Of course, Dr. Damaris and her lab, who have done all of this excellent work that I'm glad to share with you today, the Retinoblastoma Research Advisory Board, and then these are just some of our many supporters. Thank you. So next we have Sarah Green, who will speak to you about her experience as a pediatric nurse practitioner.
Thank you, Kaitlyn and Abby, for coordinating this session, and thank you for the organizers for inviting me to speak today. So I was asked to speak on the topic of advocating for the child with retinoblastoma and with a patient and family perspective of how families and patients can be self-advocates. So I started with a slide that talks about the layers of advocacy, and in this most center circle I talked about the child as being the center, but we could also say the adult or the patient, whoever that person is in the lifespan of their retinoblastoma. And going out from there, talking about the patient and from the patient, we talk about the family and the parent. So they're the first level of advocacy for that child going through their experience. and they're going to be helping their child throughout the time of their life. And then moving out to the next circle, you talk about the medical team and all the great professionals, of people that are working with the team. And then the larger circle is our community and society. And I think that there should be probably arrows that go in both directions, because we're all learning from one another. And all of us here today are advocates by being here, speaking for families, speaking on their experiences, patients who've gone through their treatments, and all of us as providers, so that we're hearing from patients and families and being able to take back all of that information to our own institutions, communities, and beyond. So when I talk about the retinoblastoma team, there's probably many more individuals that aren't on this slide, but I talked initially about the primary team of our ophthalmology and oncology team. And then beyond that, there's many players that are involved in partnering in the care that we deliver to patients. So that's sometimes a dietitian, it's our child life specialists, and advocating for the psychosocial needs of our patients, anesthesiologists, and many eye exams under anesthesia that our patients are getting, the psychologists and social work teams that are working with patients, as well as radiation oncology at times, ocularists, our genomic medicine, and pediatricians. And we had a wonderful presentations yesterday about kind of communicating all of that information back to your pediatrician, both in the early in diagnosis and making sure that patients are getting to the right places, and then also when you're done with your initial treatments, of going back to the community and being an advocate for yourself and for patients going forward. So I think advocacy really is a trajectory that you start at diagnosis, you go through treatment, and then long-term survivorship and surveillance. And as each of the slides next are going to kind of go into more detail on all of those details. So at diagnosis, we had, again, a great presentation yesterday talking about how do we, actually get patients seen and into the care that they need. So when a patient or a family member, grandma, grandpa, somebody's taking pictures, they notice that the child has an eye that looks, different in the picture that they're seeing. The family member notices that something different, that eye has strabismus. Making sure that those types of things are actually heard by, providers, and that if a provider says, you go to your pediatrician and they said, oh, well, let's watch it, a parent being able to say, well, I want another opinion. I want to see an ophthalmologist. I want to see somebody special to see my child. So in the next part, I talked about some understanding of the RB diagnosis. And again, we had just another great presentation on how informed consent, and all the information that we would hope people would include in an informed consent. And that, in our process is including all the different topics of informed consent. And then understanding the RB diagnosis. So in our institution, we make sure that patients are meeting both the oncologist and the ophthalmologist initially, and that they have that opportunity to hear from both sets of providers. And that really gives a chance for a family to be able to hear both sides of the picture and to get their questions answered. And then I talked about some child-specific interventions and how are you going to, if the child is 2 or 3 or 4 years old, how are you preparing your child to go through treatment? So in terms of treatment, I think that there's a balancing of the physical and the psychosocial needs that a child has. So we all know that, if the child goes through systemic chemotherapy, that they're managing the symptoms of potentially the nausea, the vomiting, diarrhea, constipation, all those kinds of things. And I think, are pretty well aware of those things, but just as important as managing the child coping with their treatment, involving child life therapy, making sure that people, that as a parent, you're bringing all of those things that have worked for your child in their regular life to this experience and advocating. So, if you go to the lab for, say, and a patient, they say, well, we always draw the labs here, we always do it this way. Being able to say, well, this works best for my child, and, being that frontline person to advocate for your child and their experience through treatment. Additionally, especially for the frequent eye exams, and if you're working with your anesthesiologist team and saying, in some institutions where that's incorporated, being able to say, well, this worked for me every time my child came through, or this doesn't work for me. or my child. And then continuing the advocacy after the actual treatment is complete, I divided it into 4 boxes and said, a school and work component, a vision component, a psychosocial support component, and how to actually help your child be an advocate for themselves as they get older. So in an educational environment, I know when I have kids come into my clinic, I will start very young, talking about when the child is entering their preschool years and in their school age years, being able to say that you need to talk to the school, go down there, talk to the principal, your teachers, explain to them what your child's needs are, advocating for being able to say that I want a evaluation done. Here in the United States, it would be like having a neuropsychology testing in order to get something, either maybe a individualized education plan, which a lot of oncology patients are able to have if they have some sort of a disability, or if that's not what their needs are, then potentially a 504 plan would be something that they could have if they needed preferential seating in the classroom, or being able to, just to have time they need to be at appointments and things like that. But starting early, speaking often with them. I know in our institution we have, as part of our life clinic, they spend a lot of time additionally speaking about educational needs, and we have another acronym for another program that's in our institution called the STAR program. And so there's a person specifically dedicated to helping, and a lot of institutions will have this school reentry. And it's, in other cancer diagnoses, it may be reentry after, having just their cancer diagnosis and going right back to school. For these kids, it may be going, a couple of years that they've been out of treatment because they were quite young when they were treated, but now that they're going and entering school, they need that additional support in making that. And then in our institution, we have a lot of non-English speaking families that it adds an additional layer to communicating with the school, and our liaisons can be a good advocate for helping families know what kinds of questions to ask, and if they're not getting the support that they need from the school, this individual can also help with contacting the school. I put another arrow to post-secondary education in that. I talked about the Office of Disabilities. So, as the child gets older, they're now going to be their own advocate, and being able to connect and bring those services that they were receiving in elementary school, middle school, high school to a university setting. And that might be, if they needed special accommodations in their classroom or housing accommodations, and being able to reach out to that as well. And I've added a piece that says the adult rehabilitation services, and that would be not specifically for an educational setting, but it's, like workplace, and being able to, and as an adult, to continue to receive the services that you need in order to be successful. So I added this kind of pyramid shaped with 3 different components of vision support services. So in Southern California, we're very lucky to also have the Braille Institute right very close by our hospital. In addition, we have a person that works very close with us from the Institute for Vision, it's called, and she helps a lot of our patients with, who've had enucleations, and the preparation for being able to kind of understand what that process will look like, and showing the eye to the family and everything. But she also is a great support for the vision services that patients would get either in a birth to 3 program at their home or when they enter school, and being another layer of advocacy, helping families with that piece. And I mentioned before the educational accommodations specifically for vision support that a person may need, whether it's in large print for their books, Braille services, an aid in the classroom, and then adaptive equipment, and getting the specific equipment that you would need to be successful with your vision support. And the slide specifically talks about psychosocial support. So as a parent, we want our children to be have a very positive self-image. We want them to feel that what they're what they bring and what they have from retinoblastoma is not going to prevent them from being an active and contributing person in society. So we providing opportunities for a child to express their thoughts, feelings, concerns throughout their childhood, giving that space. Everyone's culturally different in how they'll handle those situations in their house, but allowing kids to say, what is it that worries you? What kinds of things are you noticing at school that are concerning to you? And being able to give that space to talk. And I talk a little bit about generating a cancer story. So how does your disease trajectory go? So how are you helping the parent helping the child generate a story from their diagnosis through their treatment, and being able to then access that story when they do enter, into school and social situations, so they have something prepared that they can talk about. Accessing mental health services is really important, and not having a stigma or shame approach to that. It may not be something that the child needed initially when they were diagnosed at a very young age, but there's, if they went through enucleation, if there were changes to their, if they received radiation therapy or changes just in terms of they had a breakout group yesterday about post-traumatic stress of going through of your experience, and knowing, and additionally for providers to know to refer patients to that. And then connecting with support groups and organizations, which One RB World is a great place where we can all have an opportunity to connect. And then my last slide is on self-advocacy, and it really is something that starts at a young age. As soon as kids can, talk, and they're in my clinic, we talk about the kinds of things that we're doing at our exam visits. I frequently will ask patients, what is it that you think you're here for today? How do you, what is it that you understand about your diagnosis? And kind of using that as a stepping point for families, if they haven't had that conversation, to give them the tools to be able to discuss at home further conversation, because sometimes you just need that initial boost to have that conversation at home. We talk a lot about, in our clinic, managing your own healthcare, and that's, in transitioning to our long-term follow-up clinic. I specifically will ask, kids to, that these are the kinds of things, as the age developmentally appropriate questions, but that they, know the second malignancy risks of what they could see. So if I talk about, I want you to tell your mom or dad if you're having bone pain, if you notice that there's a new area of your skin that looks different, if you have symptoms of, sinus congestion or things that just don't seem normal and they're going on for longer periods of time, that we want you to be able to be aware of those things and tell your family, and then that leads into adulthood, that they're able to do that. We talk a lot also about, just general health kinds of things, that you're somebody, regardless you've had a cancer, regardless if it's bilateral, unilateral, that we want kids to always be going for their annual visits, they're getting their vaccinations, they're seeing dentists, and making good health habits for lifelong care. And then engaging, like I said, in the conversation of creating your own story, being able to engage with peers. Some of our families have gone to the schools and they've actually explained what it is to have an enucleation, bringing an eye with them and talking about that. And sharing those stories, and that oftentimes in younger kids is really what they're looking. Kids are just curious; they just want to have some information and know about what is it that the kid is, that makes them that look a little bit different than maybe their peers did. And sometimes that just opens up the conversation and takes away some of the bullying and stigma that goes associated with those kinds of differences. And then in terms of cultural and workforce discrimination, obviously we have families from China, and there's a lot of the cultural differences that some families don't want their child to know, and they don't want they'll move back to China, they don't want their peers or other people to know, because there's differences in discrimination that will go on in the workforce. I think hopefully here in the United States that's less of an issue, but in terms of worldwide, again, having the conversations of the tools and what's going to work best for that child to be able to be productive and happy and successful in their life. And the main overall thing is that advocacy leads really to empowerment. So as we, engage here today and we bring our information back to our own communities, being an advocate for ourselves, our patients, and for families. So thank you.
Thanks, Sarah. That was great. Now I'm delighted to introduce you to Amanda Brody, who will speak to us about her experiences as a child life specialist.
Thank you. Good morning. So what I'm going to talk to you about today, my hope is that it's not something necessarily just for a child life specialist to be able to help with, but for any medical professional and also for parents. Of course, I love child life, and I would love for everyone to have a child life specialist, but I know that not everyone does. So these are things that I think can be pretty simple that can be helpful. So preparation, I think one of the most important things to know is what do patients or parents already know. A lot of times we have patients coming in and they might only have a day or two before a decision has to be made. So there might not even be a lot of time for this because, we have families who are coming in and they come in, they meet the doctor, they meet the nurse practitioner, the nurse, and then all of a sudden it's, okay, we might have to do an enucleation or, and they have all these choices. Well, there's not a lot of time for preparation necessarily. But when there is time, we want to know, what do they know and what can we do? And a lot of times because the kids are so little, it's not necessarily focusing on the kids, but it is focusing on the parents and what they know and how we can help. Also providing details about what to expect. I think, I see families come in and it's kind of that deer in the headlights look and they're far from home and they have no idea what's going on. And so a lot of times we can come in and our goal is just to help let things settle for a minute because, they have a break from hearing all of the details about perhaps scans or doing an EUA or something like that where it's an opportunity to just look at them and say, how are you feeling? And just kind of let them talk. And at that point, they might actually be able to come up with questions that they haven't been able to formulate yet. So that gives them the opportunity to think about things that they're worried about or even think about a child who's at home that, not the child who's at the hospital, but a sibling who's at home that might have questions. There we go. Okay. So preparation with photos. So a lot of families who come, they have no idea what to expect. So this to medical professionals might seem very simple because these are things that we see a lot. But for the family, this might be something really simple that they can see, just a photo of, what they're going to be experiencing afterwards. So there's a book that I'm sure a lot of people utilize because I haven't been able to find another one, My Fake Eye. And that has all the details of what to expect when you go in to get an exam, and then afterwards, what everything is going to look like and what their experience is going to be like. So, to us it might seem simple, but to the family, it's incredibly important just to see something that they're going to see afterwards. There we go. Okay, that's the ticket. All right. So support. For infants, a lot of times it's just diversional play while they're in the room. So that way their parents can focus on talking to the medical team. We're kind of keeping them busy and happy because in all honesty, there's not much that we can say or do to them to help them prepare for what they're going to expect. A lot of times it's afterwards that we're helping them. Toddlers and young school age, we can do medical play because what we know is that, they wake up and they're not going to be very comfortable. They're not going to appreciate that they have a patch on their eye, and all the things that they have to experience afterwards. So a lot of times it is follow-up medical play. There might not be a lot of time to do that before, but we feel that that can be just as important doing that afterwards. And then manipulation of the prosthesis, if this is possible, when it feels appropriate. We have had a couple of patients who have come back and their parents have said to us, our child absolutely does not want to touch his prosthesis and we don't know what to do. And there are other kids who are absolutely fine with it and they have no problem, but those are things that we can help with. And, it might not be the same concept for every child that's going to help them, but, anything that we can do to help them feel more comfortable is really important. And also reminding parents of what their kids still can do, because I think it's really easy to come in and think about all the things they're maybe not going to be able to do. But a big thing is that they might not be able to do those things the way that they used to, but that doesn't mean that they can't do them. It's just an adjustment. It's figuring out how to do the things that you still want them to do, but in a different way. And also introduce them to parents who can provide insight and support. This is something that I do with patients not with retinoblastoma, but any of our patients are oncology patients, because I always tell them that I can tell them everything I know, the medical team can tell them everything they know, but I have not been through it, so I can't say this is how it felt, this is what helped us through the process. So that for me is one of the most important things that we can do for our families. And then also, speaking of support, so some of you probably know Dr. Brennan. She takes all of our retinoblastoma patients at St. Jude, and one of the things that is helpful for my job is her, because she is absolutely the best advocate for our families. When she comes in the room, it is not a rush. She sits in there, she takes as long as they need. She sits there, she listens. She's not rushing them to get to an answer. But one of the things that she and I talked about before I came that's really important is communication, because she might be talking to them and then they're seeing the ophthalmologist that might be telling them something, but she said from what she hears, one of the hardest things is when they're hearing different things from their physicians and other members of the medical team. So she said what is most important is communicating, and that might be a meeting between everyone, or just making sure that the medical team is communicating the same thing to the family, because it's a lot to process as a family. And so if everything that is being heard is the same, then that makes it as easy as it can be for the family. And then support for siblings. I know this is really small, but I'm just going to read through it. So we put together a letter for siblings, because that was one of the main concerns that we had from parents when they came, is they said, okay, well, our child is really young and we can't really talk about it with them, but we have a sibling who's at home and who's really worried about their brother or sister. What do we do when we come home? How do we explain that? So what we did is we came up with a very simple letter, and it's from the child life specialist. It says, my job at the hospital is to make sure that all the kids and their brothers and sisters who come to the hospital understand why they have to be here. I'm sending you this letter to tell you some of the things that are important for you to know. So just some of the things that we'll say is, your parents told me about you and that you know some of the things that are going on with, say, Mary. I heard that one of Mary's eyes is sick. You might have heard people saying that Mary has a tumor or cancer. Do you know what a tumor or cancer is? And so we don't just give this to the parents and say, best of luck when you bring this to your child, but we go through it with them and say, if they ask this question, these are the types of things that we would say. So that way they feel confident going home that they can answer these questions. So there's an entire letter that has a lot of information, and my information is at the end of this presentation. I'm more than happy to send it to anyone. You can change it however you need. This has been really helpful for us. And then also with siblings, something that we talk to the parents about is we have no idea why this happened, but we are at the hospital to know how to make your brother or sister better. We always talk to them about how cancer is not contagious. I think when kids are younger, they think that everything is contagious. So if they see something that's different, they might think that somehow they can get that. So it's really important to help them understand that. And then also telling them that their brother or sister may look or act different at times, but is still the same brother or sister. And I think also being able to give the brother or sister a job. It might be something really small, like going to get the child's blanket, because that way they're going to feel like they have a job and that they're helping and that they're a part of this as well. And then advocating for families. So one of the things that we like to ask is, what are you hoping for? They could talk to us about what they're hoping for clinically, what they're hoping for in the psychosocial realm, or even, they're hungry and they want some food. It doesn't matter what it is. We just want to know what they're hoping for in general. And then encourage them to advocate for their child's needs. So Sarah did a great job of talking about this. We're always going to say that. I always tell my families, it doesn't matter if you think that the doctor told it to you 5 minutes ago. It's okay to ask and say, I know you just told me that, but I have no idea what you said, because there's a lot of information right now. So feel free to ask questions. Feel free to ask if something can be done another way. I always tell them the worst thing we can say is no, and we'll say it really nicely, but we might say no. And then also be present and assisting for advocating. So a lot of times as child life specialists, we do what I call therapeutic stalking, because we try to just kind of sit outside the room on that first day and make sure that we can get in there, because like I had said before, a lot of times it is the time with us where they feel like they can settle for a second and they can come up with some questions. So they might come up with a question that they forgot to ask their doctor. And so I'll say to them, when the doctor comes in, why don't we ask them that? And because a lot of times they can forget these questions they have. So I often give them a notebook and just say, take this, write down any questions that you have. If you go home and then you think, oh my gosh, we're having a nucleation tomorrow and I didn't ask anybody, just call the hospital and somebody can help you, or you can always ask that morning as well, because I think there's this feeling of helplessness a lot, and we want to make sure that we can make that feeling dissipate as much as we can. And that is all. Thank you.
Thanks, Amanda. So our last presenter is Sarah Hancock, and she's here to talk about parent intuition. And I should also note that Abby White helped to bring us together and also helped to put the session together. So thanks, Abby. I know you're watching.
Thank you. I'm really short, sorry. Hi, everyone. My name is Sarah, and I'm Damien's mom. And a lot of you probably may not know me personally, but I'm sure you know my son's story. He's pretty famous in the retinoblastoma world. He was Damien Creed, and he had unilateral, non-hereditary retinoblastoma. He passed away November 5th of last year. This is my first time speaking publicly, so forgive me if I tear up a little bit, but it's still new. Thank you. This is my baby. He was my patient. I am a momcologist. We say that in this world, momcologists, we're kind of, I was changing Damien's diaper one morning. We were headed to the beach, and I saw that his pupil was dilated and fixed, and we took him to the emergency room, and by that afternoon, he was on a helicopter by life flight flying to a children's hospital who specialized in this. I heard the words cancer. He was 2 years old. My world changed in an instant, and I became a momcologist. I became his doctor, his nurse, his advocate, his mom, his world. I mean, everything changed that day. So to say a momcologist, it is a real term. It's serious. It is true. We do advocate for our kids. And I think that we are the most important frontline person for our children, because no one knows your child like you do. No one. So this is Damien. Oh. See, it's not working. I got it. Okay. Oh, did I go too far? Oh, sorry. So this is kind of like my resume, is my presentation today. My residency, Damien was diagnosed May 25th of 2014. As I said, I was changing his diaper. Just a normal day. He had been rubbing his eye that weekend. I thought nothing of it. I didn't notice the leukorrhea in any of his pictures. Upon looking back, there are 2 pictures that stand out to me that have the white eye. But I missed it. I didn't know. Damien fought retinoblastoma for 2.5 years very valiantly. He was truly a hero. He had countless exams under anesthesia with laser. He had 7 cycles of intra-arterial chemo. I'm not a fan. He went through enucleation after that. He then metastasized on September 8th. He had proton radiation for 6 weeks at UF Proton in Jacksonville. That's where things kind of turned around for him. He kind of became his own advocate. He found his own little voice, and he found his own way of doing things, and he would tell the nurses how he was going to do it. No, we're going to do it this way, and no, I don't want my blood pressure taken today. He found his voice. It was really interesting, and I think it was the consistency. It was the same nurses every day, 5 days a week for 6 weeks, and he came out of his shell a little bit. He became less afraid. It was good. He then went through 6 cycles of systemic chemo. This was to include neutropenia, sepsis, countless platelet transfusions, blood transfusions, lab sticks, He then made it to stem cell transplant, and he did very well. His transplant date was June 9th of last year. and we were deemed all clear, and then he went for a clinical trial in New York City. He was to be one of the first kids to do the 3F8 neuroblastoma trial for leptomeningeal spread, and he did the test dose, and then he fell, and we did another MRI, and it's crazy how fast retinoblastoma spreads. September 7th, his scans were clean. He had clean spinal fluid, and September 27th, they sent us home on hospice. So 20 days, it completely took over him. 20 days. I just want you to know how fast it can spread. During his battle, I chose to learn everything I could. I wanted to give him the best chance of survival. I myself reached out to, the top doctors of the world. I reached out to Ira Dunkel. I contacted Sloan Kettering. I contacted CHOP. I was like, what's your protocol? I researched my own. I wanted to know what we could do to save my son's life. And I advocated for him. We went through all of these treatments. Not because it was just recommended. I asked and asked and asked, what can we do? What can we do? What can we do? Oh, sorry, I did it again. Oh, I went too far. Sorry. So I am an advocate. I've learned a lot from this experience. I've learned to always follow your gut instinct. Make your doctors listen to you. If you're not getting results, go higher up. I advocated, Damien would always rub his head. When he was progressing or when it came back, when he was relapsing, he always had the same thing. He would do this. And it didn't have to be the eye that was removed. It wasn't because it was dry, which they told me. It was because he had increased pressures. And I knew that, and he would always do this. I would say, does your eye hurt? My head hurts. My head hurts. I said, okay. I would tell his doctor, if his doctor was, we just had an MRI 3 weeks ago, I'm sure it's fine. We just had one 6 weeks ago, I'm sure it's fine. I pushed, I'm like, please, just to shut me up. Just make me happy. We would do an MRI, it always came back positive. I always knew my son. No one knew him like I did. No one was around him like I was. I was with him 24/7, all the time. I knew him. I called the CEO of Nicholas Children's Hospital one time to tell him to push for an MRI because I wanted it. His doctor wanted it. They didn't want to do it because it wasn't within their protocol. They did it. It was positive. At last resort, get a second opinion. If you're not happy with your doctor, or even if you are happy with your doctor, he could be the best doctor in the world for this. He could be renowned, he writes books. Get a second opinion, just to make sure that you're doing the right thing. This is your child, period. Don't do what I do. Don't try to please your doctor. This is your child. Don't be afraid of offending your doctor. This is your child. Your doctor shouldn't be offended. If your doctor screams at you, and I've heard of this, because you are asking for a second opinion, that's a red flag. Get a second opinion. So the answers aren't always in textbooks. The doctors write a lot of books. They're great. I love doctors. I love retinoblastoma. I love what you guys do. I appreciate what you do, but you don't know everything. Sometimes moms have that instinct. You can't explain it. No matter how much I researched, I always trusted my intuition. It was always right. No one knows your child like you do. Watch for the subtle changes. When Damien would say, I don't want the shades, no sunshine today, Mama, no sunshine. That meant he didn't want the shades open. He was sensitive to light. Something was going on. Follow that. Listen to that. He would wear a baseball hat in the house. I picked up on that on day 2. That was a sign. He didn't want the light. It was bothering him. If he wanted the TV turned down, he was sensitive to sound. That's a sign. They're all signs. Just listen to your child and look for the subtle things. Damien was pretty nonverbal until age 3.5, almost 4. You have to just watch them and learn from them. Sometimes they're not verbal, and you just watch the symptoms and the signs. No one's around your child more than you, even the doctors. They have books, but your experience it's second to none. And use your resources. I reached out to other institutions. When I called Ira Dunkel, he said, you know what? I already know about Damien's story. Your doctor's already called me. Great. That gave me peace of mind that all that was doing to be done was being done. I researched online. I didn't just Google with WebMD. I actually went to Sloan Kettering's site. I went to CHOP's sites. I looked at their clinical trials. I wanted to know. I talked to other parents. I talked to other parents in the hospital with, the kids that have retinoblastoma. I still do. I talked, the Facebook groups. RB Moms is an amazing resource. I've learned so much from that group. Momcology groups, they're amazing. The prosthetic, the prosthetic eye groups, you learn things like from there. Is it normal? Should you take your child's eye out all the time and wash it? You learn things. You research things, and you hear from other parents' experiences, and sometimes your child needs that. Damien he didn't love his eye, but I learned that was normal through talking to other parents online. I love the RB Moms group. It's amazing. It's not working. And keep advocating. If you aren't comfortable with the decisions you're getting, get a second opinion ASAP. Retinoblastoma spreads very fast. Wasting time getting a second opinion is not going to help you. If you are uncomfortable with your team, or you just want that second opinion for peace of mind, get it. And it doesn't end with him. I'm still an advocate. Just because my child is gone does not mean I don't advocate for your children, because I do. I love your children, and I will do whatever it takes to not have this happen again, because it's horrible. There's Celeste. She died, 4 days after Damien. Also unilateral. Garrett was diagnosed at age 10. He died at 12. Sarah, she was 5. Josiah was 3. Come on. Paula, I believe she was 5. She's in Spain. Another angel. Max just died recently. I believe he was 7. Max passed away secondary cancer. He had unilateral retinoblastoma as well, and he passed away of leukemia secondary to retinoblastoma a couple of weeks ago. Come on. Bella, she's from my hometown in Michigan. Another little girl, she was 3. And then there's my Damien. As you can tell, he was very full of life. He loved Spider-Man, hence the colors in my presentation, red and blue, sorry. He was a very happy child, and his superpower was love. He honestly loved everyone. That's it, guys. Oh, sorry. So I run Team Damien. We take gift bags to kids. Damien actually is the founder of Team Damien. I'm just the one running it now, his dad and I. For his birthday, his 4th birthday, he had already metastasized to the spinal fluid. We knew he was terminal. We were trying what we could, but we knew the end result. We were hoping to change it, but it was always in the back of our heads. So Damien wanted to, he called the kids in the hospital his friends, because he didn't go to school. He wanted to have a birthday party with his friends. So we had a big giant birthday party for him. We knew it would be his last. Had everybody bring toys, and we put together these great big bags of these toys, coloring books, Play-Doh, crayons, puzzles, things to do in the hospital. And we took them on his birthday to Miami Children's Hospital. Huge hit. We had all this stuff left over. We kept doing it. People keep sending me stuff. I keep doing it. Now it's kind of a thing. now it's on its way to being a nonprofit. We're going to keep doing it. I'm going to continue advocating. I'm going to keep fundraising. I'm going to keep talking to moms and dads. I'm going to keep coming to these things, and I'm going to keep telling you. Team Damien's here. So keep advocating for your kids. I will keep advocating for yours. I'm going to change things. You're going to keep seeing me. I love you all. Thank you.
Thank you so much for that moving presentation. Do we have any questions?
I didn't cry. I'm so happy.
All right, thank you guys for a really, as Kaitlyn said, moving panel. You're an inspiration, Sarah, and Damien is as well. So, it's now time for lunch and a box of Kleenex. So lunch is going to be in the Chesapeake room next door where we were yesterday, and we will begin back here at 1:30. Right? 1:30? 1:45. Okay, thank you guys.